Cauda equina syndrome is rare, with an estimated incidence of 1 to 3 per 100,000 annually. There are around 8,000 suspected cases per year, with a 3 to 5% positive rate from MRI scans done. For confirmed cases, treatment is urgent surgical decompression as soon as possible. Peak incidence is at 30 to 50 years, often working age adults with disc herniation. There is a slight male predominance, but it's like looking for a needle in a haystack. Over 1 million patients present to UK emergency departments every year with back pain, in whom we need to consider this differential. Pathophysiology. Cauda equina syndrome results from compression of the cauda equina nerve roots, which are L2 to S5. This affects bladder and bowel sphincters at S2 to S4, perineal sensation and motor function to the lower limbs. Sensory symptoms are more common and earlier than motor because sensory fibers are more superficial in the nerve root bundles and more susceptible to compression. Motor impairment often indicates a late-stage Cauda equina syndrome. The sacral nerve roots S2 to S4 are more vulnerable in the narrow canal, affecting saddle sensation and sphincter tone. The chart shows the relative predictive value of various signs and symptoms, including urinary retention, perineal sensation, bilateral sciatica, saddle anesthesia, loss of anal tone, bowel incontinence, a late feature, and sexual dysfunction, which is often underreported. No single feature is reliable alone. The combination of red flags and new-onset bowel, bladder, or sexual symptoms is crucial. Musculoskeletal back pain can cause immobility due to pain that can mimic the weakness from Cauda equina. This can masquerade as lower limb weakness. Pain inhibition can mimic urinary symptoms, and the opioids that patients take with mechanical back pain can cause constipation and sometimes mimic bowel dysfunction. When assessing back pain and leg symptoms, it's important to consider several common differentials beyond Cauda equina. Lumbar disc prolapse without Cauda equina is extremely common and often presents with sciatica but without red flag symptoms. Spinal stenosis is frequently seen in older adults, and it can mimic Cauda equina syndrome but tends to develop more gradually. Piriformis syndrome can also cause sciatica but doesn't involve bladder or bowel dysfunction. Peripheral neuropathy may lead to leg symptoms but does not cause saddle anesthesia or perineal numbness. Conus medullaris syndrome is similar to Cauda equina but usually presents with more symmetrical symptoms and earlier motor weakness. Finally, functional neurological symptoms are common and can resemble serious conditions. However, they require careful assessment and exclusion of organic causes. There are many others which we have not covered here. This diagram in this slide illustrates the prevalence of some other serious conditions. As expected, serious spinal pathology is more common among patients presenting to emergency departments than in primary care, although the absolute numbers remain low overall. For example, spinal fracture occurs in approximately 0.7 to 4.5% of patients in primary care and 6.5 to 7.2% of patients in emergency departments. Spinal malignancy is found in 0.7% of primary care cases and 2.1% in ED presentations. Spinal infections are rare in primary care, 0.01%, but increase to around 1.9% in ED. Cauda equina syndrome is extremely rare in primary care, 0.002%, but may present in 0.07% to 1.9% of emergency department cases. These figures reinforce the need to consider serious differentials appropriately without over-investigating the majority of benign back pain presentations. The wide range for Cauda equina in ED, 0.0% to 1.9%, is due to differing study populations. The upper end usually reflects highly selected referred cohorts or MRI-based audits rather than general ED attendees. Primary care data often includes patients with non-specific low back pain, many of them, and so very low base rates are expected. The Getting It Right First Time recent Cauda Equina report focuses on improving early diagnosis and reducing variation in management. Key points include focus on new onset within 14 days symptoms involving bladder, bowel, or sexual dysfunction or saddle anesthesia. Prompt MRI within 4 hours of recognition of red flags. Recommending clear regional pathways and access to 24/7 MRI, avoiding over-investigation, being proportionate with imaging, and encouraging shared decision-making and accurate documentation. Moving on, post-void residual scan is a useful, quick, and non-invasive triage tool, with less than 50 mL being normal, 50 to 200 mL being indeterminate, and greater than 200 mL being suggestive of urinary retention, which is a strong red flag for Cauda equina. This is an objective test or measure for urinary dysfunction, one of the strongest red flags for early Cauda equina syndrome. Digital rectal examination has many limitations, with a low sensitivity, inter-rater variability, and anal tone being subjective and difficult to assess reliably. It's better used as an adjunct rather than a sole discriminator. Cyclists, for example, can also get pudendal nerve anesthesia, which can lead to reduced anal tone. Bilateral sciatica is listed as a red flag, and that's important, but it's important to also know it's common in spinal stenosis or central disc bulges. It indicates a large central disc, which is a risk factor for developing Cauda equina in the near future, but on its own probably isn't a feature of Cauda equina at that moment. However, for now, bilateral sciatica is still in the guidance as a red flag and should be respected as such. It's more concerning particularly when it is new in onset and associated with bowel, bladder, or saddle symptoms. In summary, Cauda equina is a rare but high-risk condition, difficult, requiring sometimes senior decision-making, with a focus on new onset bladder, bowel, or sexual or saddle sensory changes within 14 days, combining history and post-void residual, and examination to triage the MRI need. The Getting It Right First Time guidance pushes for fast MRI when justified, but discourages overuse, using a structured red flag checklist, including saddle anesthesia, new onset bladder, bowel, or sexual changes, post-void residual more than 200 mL, documenting time of symptom onset, using the post-void residual scan, a careful history and examination to defer MRI if no clear red flag signs, and if there are no Cauda equina signs, one would follow up in musculoskeletal or spine clinics or community physiotherapy. The Getting It Right First Time guidance is one of the newest pieces of evidence and an extensive report, and can be used as a tool and an indication for this condition. I will include a reference on that below. And just again to appreciate that this is a difficult presentation for many reasons. One uses the guidance and develop clinical acumen, including the patient in shared decision making